Thank you very much, Brunel. I mean, it must have been and probably still is very hard to live in India with the COVID going on. I think all countries have had a lot of different difficulties, but all the issues that you have raised, I don't think we all had those, and they seemed really quite I don't know, horrible, that all of this discrimination and all these things were going on without, doing it, putting human against human. Whereas I think in South Africa, as rightly you remembered us, you reminded us, the issue was that Ubuntu actually brought people together. Is the opposite in India. So let's reflect. Maybe we have a bit of time to discuss. It is my turn now, so I'm going to try and share my screen and find my presentation. There it is. So whilst Brunel takes some breaths, it's my turn not to breathe. So, okay. So my presentation is entitled "The Need for a National Strategy for the Provision of Culturally Competent Spiritual Care and Support During Major Health Disasters." It has been raised, I think, by everybody that health governments, health organizations, and health practitioners were caught unprepared. And here it is really to look at what would my emphasis is really on the components of such a strategy. But the focus of the strategy, the preparedness strategy, is about spirituality care. So I conducted 2 studies with my colleagues during 2020-21, and you can find both of those studies and the reports, full reports, in the website that the link is given there. So I want to discuss the importance of spirituality and spiritual care in nursing and healthcare, some of the background of the challenges and impact that COVID-19 had in the UK. So my presentation is about the UK perspective, okay? The motivation and the aims behind the 2 studies that we've conducted. The first one, it was called Spiritual Support for Hospitalized COVID-19 Patients during March and May 2020. And the second one, as I've already mentioned, is about developing this strategy for spiritual care and support during major health disasters. What I'm going to give you is really very, very brief and very, very strictly compressed and summarized. So in terms of the importance of spirituality and spiritual care in nursing and healthcare, we have loads and loads of evidence. We have books about spirituality in nursing, we have articles, we have art that from thousands of years going back, that presents this the link of spirituality and health. Of course, we don't. In the report, you will find a reasonable literature review about the topic and its importance. But just to mention a few things is that obviously research has given us a strong uh, suggestion that spirituality is an integral. I'm going to move my before so that I can read my slides. Move this out now. I'm going to minimize this. Okay. Otherwise, I only see half of my slide. The yeah, it is we human beings are made up of mind, body, and spirit, and we actually talk about that in our nursing training. But what happens is often, and what has happened, especially during the COVID, it was that the body was given priority. Obviously, the mind also had a lot of attention, but the spiritual aspects of care were really they were at the bottom of the pile, let's say. So research has also found that very ill people and those dying find comfort from a prayer or just the presence of someone who can hold their hand and be with them as they take their last breaths. And as an important element of people's culture, spirituality promotes healthy behaviors. In obviously not only in normal times, but also during pandemic. If you think about this topic, so there are more positive gains in our psychological state, and also strengthening social networks. And people talked a lot about, well, Mavis and I think Rowena talked about the strengthening of social networks. Of course, it was the opposite in India in many ways. Why did we want to do this when the pandemic hit the UK in the early 2020? We were listening very quickly the death rate and the cases increase very, very fast. And the hospitals were overflowing. We had lots of other issues with PPE provision, with oxygen, with intensive care provision, and so forth. And a lot of it was we were coming across in the social media and in the mass media of stories that people were deprived of dying alone. Of course, no relative or friend or anybody else in the early stages in the pigs were allowed to visit a person who was in hospital. Only the healthcare professionals. Even the chaplains in many institutions in the UK were not allowed in. So people, young people, even children, older people were dying alone. And nurses try to do their best, but you know, when you have so many other demands on your services and so many needs to be met, and of course nurses became ill and nurses died, and nurses ran away from nursing as well because they were so scared in case they affected their families and so on. So we had shortages from illness and so forth. So apart from as I said, being motivated to learn a little bit more about what was actually happening in the hospitals during the first peak, and to investigate this issue of many people dying alone. This was the motivation basically for the first study. and which the first study aimed to answer these questions. I'll read them out because that would be faster. To what extent has the provision of spiritual support for the COVID-19 hospitalized patients been covered by mass and social media and the website of spiritual leaders and institutions and those of the NHS in England? It was it didn't cover the whole of the UK, but it was the location was England in the period between March and May 2020. How has the provision of spiritual support for the COVID hospitalized patients been represented within the mass media and all of these websites and the mass media, etc.? And has the COVID pandemic affected how spiritual support is conceived, valued, and enacted within the NHS in England during that period that we're talking about? So, and what are the lessons to learn? So we actually conducted a very, I hope you do download our reports because they're really very interesting. I think we did a very thorough analysis of tweets and Facebook messages, conversations that people were having about this topic. We looked at a couple of national papers and what they were reporting and websites and so forth. And we analyzed the data and we provided some themes that came up from that study. And the conclusion of that study was that spiritual care was reduced and was mainly given at a distance. So the chaplain would be talking to a sick patient using a tablet, or maybe send a message via an iPhone and so forth. So other people mentioned technology. We're going to mention technology as well. So there was suspension, reduction, and modification of person-to-person spiritual support. Even the holy sacraments were given at a distance, which is, I've never heard of this, and I don't know how this will impact the religious, different religions, but that was quite a surprise to me. So virtual provision of spiritual support, both in real time and in deferred provision and at a distance, as I said, and a lot of there was some creativity in terms of the things that people were doing in order to kind of maintain some closeness between and connection between somebody, talking to them via a technology and not being there with them. Now it didn't happen everywhere, and still, but particularly the chaplains tried to fill in the gaps as much as they could. So, we concluded that there was a lack of strategy for the provision of spiritual support and care, because there were no guidelines. They were being made at during the pandemic. There were no strategy. We did not find any strategies that would be put in place and be executed in an official way to respond to the needs and the demands in an equitable and quality provision way. So we recommended that there is an urgent need for the development of such a strategy. And so therefore, when it came to doing another study, the focus of that study was to identify, and the aim of the study was to identify the components of a national strategy for spiritual care and support to patients, families, and staff during emergencies. And we interviewed 25 senior nurses and chaplains, hospital chaplains. And the interview was in two parts about, their experiences up to that point, because this was during the second peak, and what they would like to see in a strategy. So the findings from part one were linked to things that they said were, we have never experienced a pandemic before. So none of the people, and and we spoke to other people informally as well, and probably 99% of the people in the UK healthcare professionals have never experienced such a pandemic. They all said that they were found unprepared. However, multidisciplinary working was more evident. People started to talk to other professionals, understanding the role of other professionals, and there was more collaboration. So that was a positive thing. The use of technology in the first. This is because this is about the first pick. It was very variable. There was it was used a lot, but a lot of people reported that there were not enough tablets. The internet was not always available or reliable. There were a mix of opinions, and obviously they recognized and appreciated the fact that there was technology, that the patient who was severely ill in hospital could see their friend or their husband or their wife, a member of family, talking to them and connecting with them. And the other major theme was that they reported it was that they were overwhelmed by the huge number of deaths, that people were dying, and there were bodies in body bags everywhere, and it is something that nurses really should know about death. They know about death, they deal with death, but this level of death, it was overwhelming. And for the recommendations that they did about the components of a strategy, they said, first of all, we have to be aware of the past. So the things that they talked about in part one of the interview, and all the things that we've reported, just mentioned. There was an issue about terminology. People, when we interviewed them and we asked them about, spirituality, they said, what do you mean by spirituality? Of course, there isn't one definition of spirituality, and it is probably the right thing because we all understand it in a different way. But we came up with components of different ideas that people, different definitions that people provided. So we do have now in our report, this is my, I will show you our lovely report because I have a hard copy of the second study, but you can't see it now. Also, terminology about the chapel, people said, well, it was a nice place to go and be, but a lot of families or when they were allowed to visit, or even patients who were allowed to move, connected the notion of chapel with Christianity and so forth. So need to be clarified, and it's all done in the report, and you can read about it. You know, the impact on the community and various aspects of that. Then, you know, I mentioned the collaborations that happened right from the beginning, and people were now more collaborative and communicating and with each other. Trust was a big issue. Trust between the health professionals and the government, who kept changing the guidelines, you know, that they gave you in the morning. By the afternoon, they gave a different or a contradictory guideline, and the staff were very tired and were losing trust of the messages that they were coming through. But the same issue also applied to the public, and you know, the amount of trust that you know, slowly that was eroded. Care and support, of course, came up a lot for the patients and for the staff as well. Training is a big issue. Technology we mentioned. Equality, diversity, and inclusivity was a big issue as well, because during the pandemic, we more doctors and nurses from minority ethnic groups actually died or developed COVID than the majority, and resources. And now I'm going to show you. We thought that in order to be helpful, because we were not developing the strategy, but whoever is going to take over and develop this strategy that we need, that we would have three kind of themes, or three kinds of action areas. So the first one was about preparation. So who is going to write the protocols, the training, the resources, and so forth. The second was the delivery of all of that, and the next one was the evaluation, which is really important, and it has to take place. So this is a visual of some of the things that I've been talking about. So we have the main themes are the red little boxes and the green boxes, the deep green. And then around each one of the themes has a number of key subcomponents that we discuss in the report and we explain and so forth. So I'm not going to go through all of them. I'm just gonna see what the time is now. We just passed up, yes. And I just want to show you how we developed this document, which will be, we think it is a very useful document, because it details all the suggestions and that we had collected from our study, and it is presented in the way that I mentioned before. So we have the theme, we have the theme and the components of each theme, and then we have the preparation, the delivery, and the evaluation. And we make suggestions about who should be responsible for the preparation, who should be, how the delivery and by whom should happen, and who should be responsible for the evaluation of the strategy. So I mentioned, as you can see, I very briefly make a comment about this. You can see the terminology and the issue about spirituality, spiritual care and support, defining chaplains and chaplaincies, and chapels, the issues about community, and we extracted the information very, very very, very carefully and in a way that doesn't overlap with the other notions. And it is very specific. And all of that could actually not only be part of the strategy, collaboration we mentioned, communication, where is my thingy for? Trust and training. So can you see the training? A lot of that information, we're hoping to conduct a big study about training now, and I am in the process. We're in the later stages of our proposal that we're going to submit soon, which focuses on training healthcare, social care, and raise staff in spiritual care preparedness, and also raising awareness and understanding with the public. So it is a very participatory project that we want to do. And there's a lot of stuff that need, we're going to do, hopefully if we're funded, we will develop a course which lasts maximum of 10 weeks, maybe 8 weeks or 7 weeks, and it will be online. And anyone can then, we will deliver it once so that we can evaluate it, but we will have it on the project website so people can take things, the components of the training by themselves, or organizations can deliver the course if they wish, all free. So technology, equality, diversity and inclusion, resources, and I think I will stop there. Obviously, none of us have given you enough detail of the topics that we have tried to cover, but I think we've raised hopefully awareness about some of the issues in different, that some of them cut across countries, but some of them are specific to the particular countries. And hopefully you can, I mean, from my point of view, you can read the two reports, but there is a lot of literature, and you can of course contact us if you need any further in the future, any further information. So now I will ask Sean to play the video that Kathy has prepared.
I think we'll need to make a minor adjustment to the schedule because Azita will need to leave. So maybe Azita can present first and then we will play the video.
Okay, that's good.
Azita, would you want to get your presentation ready?
Sure. Thank you very much. And hello, everyone. Thank you very much for this opportunity to be here today with you all and sharing my thoughts on this very, very timely and important topic. As an evidence of the COVID-19 pandemic being still very vital and ongoing, is that I tested positive for COVID this week. So I'm a bit under the weather. So please bear with me if my voice is compromised or if I need to take a pause to take a breath or cough. I was asked to share some insight about how US and the American healthcare professionals, and in particular nurses, have been dealing with the pandemic. As you know, the United States is a large, diverse, and multicultural country with complex governance, and that often prioritize states' rights and personal freedom over the common good. The country's response to the pandemic was built on a foundation. Sorry, Sean, could you just change the slide now? to the okay, yes, thank you. So the country's response to the pandemic was built on a foundation of existing racial, class, and other disparities in access to healthcare. The response was channeled and in some cases limited by the way in which public health authority is decentralized throughout the country. Next slide, please. There is a gap, sometimes a very wide gap, between the ideal of an America in which all people are equal and the reality of healthcare access for people of color. 20 years ago, it was reported that the principal finding of the 2004 National Healthcare Disparities Report is that disparities in quality of care services are pervasive at the national level. Minorities and the poor more often receive lower quality care across an array of measures. Just recently, we had another report, and that report found that these disparities have barely narrowed over the last 20 years. According to the 2021 National Healthcare Quality and Disparities Report, quality of care for minorities has only been reduced compared with the previous report by 8% of measures of American Indian and Alaskan Native population, 2% of measures for Asian populations, 3% of measures for Black populations, 4% of measures for Hispanic populations, and 10% of measures for Native Hawaiian Pacific Islanders population. So the 2021 report states that the disparate measures reflected lack of access to health insurance, lack of access to healthcare services, and lack of timely access to care. Next, please. Next slide. The causes of these disparities are rooted in systemic racism. Both systemic racism, historical events, inequities in social determinants, economics, and many other interacting factors. In addition to a history including slave trade, denial of civil rights, discrimination, and segregation, the Black population in the United States has been repeatedly subjected over many decades to interactions with the medical world that have sowed mistrust. A prime example of such mistrust is the United States Public Health Service syphilis study at Tuskegee from 1932, where 400 Black men were injected with syphilis without informed consent or treatment. For COVID-19, this mistrust manifested as reluctance to accept and act on factual information from official sources about the safety and efficacy of COVID vaccines. Next slide, please. The US Office of Disease Prevention and Health Promotion Studies shows how structural racism has created economic and social disadvantage that contribute to adverse health outcomes. It has been shown that BIPOC communities in the US suffer from high rates of respiratory illness, which make them more vulnerable for COVID, have more prevalent comorbidities known to increase COVID risk, including obesity, hypertension, and diabetes, are expressed to increase risk of the infection spreading in population-dense living situations, are more limited by economics, lack of insurance, reduced transportation options, linguistic and cultural barriers, and lack of providers. And they are usually located in communities where clinics are frequently under-resourced. All of these factors became far more critical in the face of a pandemic, where resources were limited, sophisticated high-quality care was often a life or death matter, and prompt acceptance and implementation of public health preventive measures had a significant impact. Next slide, please. Because of pre-existing inequities in access to healthcare in the United States, as well as significant political differences among the states, the pandemic widened the gulf for historically excluded populations. The penalty for being a person of color was a greater risk of dying from COVID-19, sometimes a far greater risk. Data through late 2021 shows that Hispanic people represent the largest share of COVID cases relative to their share of the total population. Black people account for larger COVID cases compared to their population share. And in contrast, whites account for a lower share of COVID cases compared to their share of the population. The burden of COVID-19 in terms of prevalence, hospitalization, but most importantly, mortality rate was disproportionately higher among BIPOC communities. A study in the Journal of Global Health showed that the COVID prevalence ratios for Black people were 156% higher than for whites, 154% higher for Hispanic Latinx, and 104% percentage higher for other historically underserved racial groups. Hospitalization for BIPOC populations with COVID-19 were seen as at the rate 2.8 times higher than white people. And Black people have died 1.4 times the rate of the white people. Please, next slide. But there were also some positive responses to the pandemic that will hopefully bring about long-lasting changes. The US responded to COVID by leveraging its technology, maximizing its advocacy in favor of evidence-based prevention and treatment, and seeking ways to close the disparity gap that was coming starkly more evident among the masses. In the technology arena in the US, the United States led the world in vaccine development effort using messenger RNA technology. We started implementing the use of telehealth, texting, chat applications, and other remote access technologies extensively. These enable people to be quickly and safely seen with minimum risk to healthcare providers and patients. And this also provided greater access to care for rural, tribal, and other areas where primary care providers were not easily accessible. Within the advocacy domain, a massive public health messaging campaign was initiated at the federal level, encouraging people to wear masks, maintain social distancing, and when they became available, get vaccinated. Each state and sometimes local governments made individual decisions about whether certain kinds of facilities could be open for the public to gather, and if so, under what conditions. Lines of communication were created for healthcare personnel to stay on top of rapidly changing developments in diagnosis and treatment. And to address disparity, we made some notable progresses. For example, vaccine was provided at no cost to everyone. Free masks and most recently, test kits mailed to homes were provided. Trained military personnel were utilized to supplement and support hospitals when they were threatened with being overwhelmed. Academic healthcare programs, students, and faculty members stepped in to help in underserved communities. And I am so proud to say that the nurses were at the front and center of this. The need for culturally sensitive and anti-biased approaches to education, prevention, and treatment was acknowledged and responded to. Please, next slide. So what did we learn? From the pandemic, more Americans than ever became acutely aware that healthcare inequities need to be addressed and eliminated. The US finally recognized that the importance of examining the social determinants of health and ways to address disparities. We learned that more and better preventive as well as acute care access need to be improved and equalized. Public health, population health, and community-based education need to be an ongoing effort in order to achieve the highest possible level of understanding and reach when emergency measures are implemented. Better tools need to be developed for presenting timely, consistent, evidence-based messaging and for countering inaccurate social media messaging and fake news. Telehealth has a critical role to play in circumstances where in-person healthcare access is limited for any reason, whether pandemic or geography. And alliance between government agencies and institutions need to be forged before there is a crisis. And most importantly, the US learned, like my colleagues, other speakers also pointed out, the US learned that nurses play a pivotal role in addressing all these challenges. Please, next slide. At the University of Washington School of Nursing, where I have the pleasure to serve as dean, we have been a leader in promoting and integrating diversity, equity, and inclusion best practices. The pandemic, however, opened our eyes to needing to address racism as a public health crisis. We recognize that nurses hold major responsibility for the health of individuals and communities that hit hard by historic racial inequity. So in 2021, we launched the University of Washington School of Nursing Center for Anti-Racism in Nursing. This is the first center in the United States to be dedicated to anti-racism in nursing practice, research, and education. Through this work, we hope to build and refine academic programs and best practices that could be modeled throughout the nation and also in the world, including cultivating anti-racist teaching practices, developing academic curriculum that ensure preparing anti-racist nurses and anti-racist continuing education for professional development in nursing practice. And developing research tools and methodologies to ensure representation of historically excluded populations and promote community-driven and partner research to prevent biases in analyzing and presenting the results of the studies. Supporting students from underrepresented and historically excluded groups into nursing and also applying anti-racist principles to clinical practice, organizational operations, budgeting, and healthcare policies. Next slide, please. In conclusion, it is a difficult reality that when the pandemic came to the United States, we responded both extraordinarily and inadequately. We were a global leader in leveraging scientific knowledge and creativity to develop highly effective vaccines. At the same time, our response perpetuated and in many cases made worse long-standing disparities in access to care. We were not fully prepared for a pandemic and made many faults in the responses needed to address it. The conclusion from these data must be that racism is a public health emergency, and healthcare inequity deserves urgent attention and mitigation because in times of challenge, whether economic or from a pandemic, disparities in healthcare access will become worse and more deadly. Next slide, please. Thank you very much for paying attention. Back to you, Rina.
Well, thank you so much for a very interesting presentation, and especially because you have done it with having, this COVID issue. Well, you didn't cough. I'm sure your lungs are going to be a little bit tired after talking for so long, but we do appreciate your contribution. So, I mean, if you are tired and you want to leave us, it is fine. So I wouldn't keep you till the end. And as again, thank you. And it's nice to see you again. And all the slides will be available on the ETNA website, so people can actually, and probably the recordings as well, so people can watch these in their own time and maybe use them as part of their teaching their students and raising awareness about all these issues and trying to find solutions and maybe reflect about the past and dream about the future. So thank you, Azita, and all the speakers. We now need to go quickly to the video, and probably will not. Just if you wish to stay behind a little longer and have a discussion, that is fine with me and maybe some of the other people. So we will do that. Otherwise, if you wish to leave after the anytime really, but do stay and watch the video.
Hello everyone and greetings from down under. It is my honor and privilege to be part of such esteemed company and to participate in this first online conference for ETNA. Unfortunately, I cannot be with you in the flesh because I am asleep during this time of the presentation. Hopefully in the near future, we can get together and share some different types of experiences rather than the one we have experienced during the last couple of years in our lives. Australia, like many other countries and places in the world, has had its fair share of disasters, natural disasters such as bushfires, floodings, other emergency situations. And we felt that we had the appropriate preparedness and we could face any kind of escalations into a crisis by activating appropriate response teams and have the ability to predict any kind of worst scenarios. Alas, we were not really very well informed because, of course, the events of the last couple of years have proven us very wrong. From the onset, we realised very early that although Australia has a robust healthcare system, the aged care sector was absolutely not prepared. Our outbreak management plans were lacking many things, some of them which were having zoning areas within a facility and designated zonings for clean and dirty areas, adequate PPE supplies, adequate training for staff in relation to donning and doffing, preparation for surge workforce. I mean, how do you prepare for something that you don't know how to roster for? Screening processes, which we really have had none of that in place. Of course, the devastating results of the very first wave highlighted all these issues and many more. And then, of course, following some of the lockdowns, we were buoyed by the fact that we have experienced periods of 0 cases or donut cases that we used to call, up until such time that, of course, the Delta strain hit our shores. And then that forced us into various short and long lockdowns and questioning again what was the effectiveness of all, and in particular upon the aged care sector. Of course, by the time the Omicron hit our shores, even though we have addressed and had the opportunity to address many of those issues in relation to the outbreak management plan, we then uncovered other gaps and other issues such as the RAT testing, the PCR tests, and the implications of its cost and supply. Australia is the largest island and the smallest continent in the world. As such, when measuring the population against its land area, Australia has one of the lowest densities in the world, with a population of 25 million and density of 3 persons per square kilometre. This little geography lesson is a segue for me to be able to put the data that I'm providing you in perspective. The 744 deaths linked to aged care in between the years 2021 have had the country on the edge, with public health officials issuing lockdown directions. We have had 6 or probably more ever since. We've had state border closures, we had international border closures, and essentially declaring Australia as the most lockdown country in the world. As of March 2022, we have 1,793 deaths relating to residential aged care facilities, and they relating to residents who have been at higher risk of other severe diseases, underlying immunocompromisations, and of course some who were not vaccinated. The Australian government was slow in rolling out the vaccination process in the belief that the AstraZeneca produced in Australia would cover the needs of all the population in Australia. When that was realised that it was not going to happen in a timely manner, the Pfizer vaccination was the preferred vaccine for the aged care sector, but there was insufficient in supply, so not everyone got vaccinated at the same time. There was a slow and poor uptake of staff at the beginning also because at the time the vaccination was not mandated for staff, but also there was a general aversion because of the several cases of deaths and clotting experienced when the AstraZeneca was rolled out in the general population. As you can see, things have improved ever since the mandatory vaccination has been introduced across the country, with 98.5% of workers in Australia being fully vaccinated now. I am very much aware that this is a global issue. The physical and emotional and psychological toll that it has taken upon all of us is something that will probably take years and years to recover and repair. But I thought that I mentioned what we have experienced during this time. The fact that loss of one life is one too many. The fact that families and relatives are searching for answers and explanations. How could this happen? How did you let the virus into your facility? The staff's feeling of helplessness and the fact that there wasn't very much that we could have done. The general fatigue that everyone is experiencing and will probably experience for many years to come. The anxiety that we're experiencing every day because we need to continue meeting our regulatory compliances and obligations within our standards. The PPE injuries that people have experienced, and of course the threat of emergence of variants. All these are real and all these are part of us having to live with. Whilst we still have cases in the community, we are now moving towards living with it whilst we're re-examining the lessons we have learned from all the scenarios, from all the lockdowns, from all the border closures, because we want to work with the world and learn from others. We want to ensure that we have all the tools to prevent any case situations from escalating into crisis. The lessons learned so far have taught us that we do need to be much better prepared. We do need to work collaboratively with everyone, and we need to have all the lists below appropriately prepared. I just wanted to leave you with the current data as it stands, and to just leave you with the thought that we are still grappling with it. It's still not over, but we are in a much better position than we were 2 years ago. I'd like to take this opportunity to thank you for allowing me to be part of this esteemed conference, and to tell you that I look forward to very much to meeting you all in the near future.
I thank Kathy for the interesting and very clear presentation and the video that she has prepared. I think she summarized a lot of the issues that we have covered in this conference very nicely. But before maybe we do some wrapping up, I just wanted to say that we have 128 people still with us. If you wish to stay and have another 5 or 10 minutes so that we can maybe tackle 1 or 2 of the questions that either is in the chat or people want to ask, that would be nice. I'm not sure, I can see a couple of the presenters are still here. So I will assume that those of you who are still around, you would like to have some discussion. So over to you, Alfonso. Are there any questions in the chat that?
So there were lots of questions around the presentations and the video, and just to reassure everyone, we have recorded the whole event, and as Rena said, the PowerPoints will be on the website as well as the video. We will put it on our YouTube channel and make it available for everyone to watch in their own time. So the questions are going quite fast now, but there was a question. I would like the second speaker to talk about the traditional assistance assisted the midwife.
Okay.
Maybe something to do how they assisted the midwives.
Yeah. I am sure that Roina understands the question very well. So over to you, Roina, because this is quite normal in many societies that, you know, traditionally didn't have trained midwives. Am I correct? So, but you know, the skills that people have are still there. Hopefully we nurture them and they will be there for a long time because there is a need for them. Unmute yourself, Rena, if you're muted.
Okay, thank you so much, Prof. And thank you so much for the question. I will start with the explanation that according to the maternal guidelines for South Africa, if the woman delivers normally without any complications, they stay in the hospital or in the clinic just for 6 hours. So this brings the issue that as midwives, we need to work together with them. We don't have a choice. Previously, we used to, in history, midwives used to drive bicycles and make follow-ups during the postnatal period. But nowadays, because of high rate of crimes and other findings of research, now it's no longer happening. So once the woman is discharged home, she is on her own with the family. And according to the findings of my study from Masters, I found that it's not every woman who's dying was discharged early as within 6 hours, which shows that it means the family members and traditional birth attendants, they are doing their best. So in my results, I realized that there are a lot of commonalities or similarities in what they are doing and what we are doing as midwives. There are just few differences where we need to, if we can work together with them, we will be able to agree and to make them aware about how risky are some of the practices that they are doing, so that we come to an agreement and find out how can we move forward in order to make sure that we prevent complications. Hence, it is very much important to work with them, because they are the ones who are bringing these women to the hospital for labor. They are the ones who are bringing them to come and book. And after discharge, they go back to them again. And now, because we are not working with them, they do anything, whether harmful or what, and few of them are brought back to the hospital with complications, but majority, they continue in healthy and safe environment in their hands. Hence, moving forward, it will be advisable for us to work in collaboration with them, so that we start trusting each other for the sake of the pregnant women and the newborn babies, that they take care for them on our behalf, because we can't be able to make follow-ups anymore. I hope I answered the question.
I think you probably have, but I know from your study that one of the things that you forgot to mention is that you and we can learn from these people, because they're the carriers of culture and customs. And although you mentioned that some of the customs may be a little bit dangerous, so that you can exchange your knowledge and also get all the positives from and make your practice more culturally competent. So it's a win-win situation. So thank you, Reina. Any other questions?
So there are no more questions. There's loads of comments around. Thank you, everyone. People are saying it's quite difficult to digest the level of discriminations going on during such difficult times as well, and the lack of support for nurses and patients. But generally, everybody's saying thank you to all of the speakers. If anybody's got questions, you can please put them in the chat. But there are a few things I want to say whilst maybe people are thinking. I see people are leaving. As I shared in the chat the link to the evaluation form. I will also email, because I can see it doesn't seem to be working for a few colleagues. So I will email the link at the end of today, hopefully. By doing the evaluation, you can also request a certificate of attendance. So if you wish to have one, do the evaluation, leave us your details, and you will get it. To answer the question from Katalin in Hungary as well, each one of your students as well, if they can do an evaluation, each student, they will also get a certificate. So just do that, and that will be great. One final thing as well, Rena, we wanted to mention about the country representatives. So we are still looking for country representatives. Currently, we're looking for members in Indonesia, Qatar, Romania, Sweden, and Turkey. So if you are from one of those countries, please do let us know. But also, if you are from one of the countries that we do not have on our list yet, do let us know as well, and we will put you on. All you need to do is send a short biography of yourself, your email address, and your affiliation, and we will welcome you as a country representative. Sorry, Rena.
That's fine. No, I'm glad that you have put all of this out there, and it is a very good opportunity to recruit people for the ETNA organization, which is very friendly, and everything we do, we all do as volunteers, and therefore we have no need for any money from you. So just so to, if there are no other questions, I just wanted really very quickly to summarize some of the messages that we've heard from the presentations. So I think really the pandemic, of course, we had some statistics and some history and all of that, but in terms of the challenges that the pandemic has created, I think we heard that it wasn't just about giving care or having medical interventions to save the lives of the people, but the challenges were also political, they were economic, there were lack of resources, there were all sorts of things. And but surprisingly, I'm not sure about what you think, but I was quite surprised at the level of stigma that this pandemic has generated, the level of hate between people from different cultures and different religions, the conflict, and actually even crime. You know, the pandemic has caused crime to criminal activities and behaviors, not just in India. I think that was kind of like, you know, some of these issues, the racism and the inequalities and the conflicts came through in some of the presentations. Now, there were, of course, good things, and there are things that have been around for a very long time, and nothing has happened. For example, you know, looking at the technology and really taking seriously the contribution that technology could make to healthcare in general, has gone around very, very slowly. As somebody who has done some work with technology, we have missed a lot of opportunities, and we have put barriers to using the technology because of our fear that maybe robots are going to take our jobs, or only humans should care for humans and all of that. And we actually did not develop, and we were not ready in terms of some technology was there, but the technology could have been much, in my view anyway, much more advanced and more useful. But it is now going through very fastly. So it's on the fast road now. So at least that, you know, the change of attitudes, and also the realization that we should not be frightened about things like that, and of course be measured as well. But so that is a good outcome in my view. So also the level of collaborations between health professionals, the fact that communities have got together and helped each other, it just kind of it gave us a lot of human stories, and to actually, for us to remember that humans, of course they can be cruel, but they are generally speaking good, and they want to do good, and they appreciate the importance. I think, we rediscovered the importance of spirituality, in my view, and we, and how humans are very, we are not kind of like undefeated. There's lots of things that, our existence depends on so many things, and having some belief about and acknowledging your own spirituality, however you examine it, is very, very important. And it provides, it lessens the stress. We talked about stresses and all of that, and it gives you hope. All these are good things. So I think probably all the other challenges and solutions that we don't need to repeat them again. They were very well articulated by our presenters, whom I thank again for their commitment and their enthusiasm to take part in this conference. I hope that you all enjoyed it, and you all maybe enjoyment, I don't know, is not some things may be enjoyable, but found it useful and found it informative, and you know, and you got some kind of, you have been inspired so that you can be part of our group, of our movement, because I call ETNA movement. The movement is that, you know, we are a bunch of people who are interested in inequalities, we're interested in cultural competence, we're interested in, you know, doing good for its own sake, for all our patients and for all our colleagues and for humanity. So, you know, join our movements and campaign. The last thing I'm going to say, we need national strategies for preparedness. My specific interest is in developing something around spirituality, because as I said, spirituality is the Cinderella of everything else. Okay, but it is very, very important. So do what you can to influence who you can, to take seriously the notion of preparing a strategy, but not just on paper and not just on a website. We want the strategy to be enacted, to be practiced on a 6-monthly or yearly basis, so that people get the skills, they know, you know, the components and how to operate when something happens, and that it is fully funded and it is also continuously evaluated. And of course, we need some more training at different levels and at different for foci, but we can do that, and we can get prepared better for the next time, because believe me, we will have more pandemics and we will have major disasters, because there is evidence that the major disasters are happening all the time and more frequently. And a major disaster which is not a pandemic or a health disaster of some sort still creates health, the need for health workers and the skills of nurses and doctors and paramedics and all of that. If you have a massive tsunami, or if you have a massive whatever, it will create death, it will create infections happening, it will create destitute, homelessness. All of these things are what we need in order to be healthy. So it is timely that we think we actually expand our thinking to those issues, not just what we do day to day. They are important, of course, but we have to have the bigger picture, and we have to make contribution to the bigger picture. And nurses, they say they are valued more because they were so important. But in the UK, when they asked for a raise, they gave them 1%. Is that valuing? Words don't pay the bills, right? It is actions that pay the bills, and it is actions that bring about equality. So don't tell me you're valued, but we don't do anything about this. You don't put, it's just an abstract something that you value, and you feel, I don't even feel happy when somebody, because I would be offended that you tell me I'm valued, but then you don't do anything to help me with to show real appreciation of what we do. So nurses are at the center, will always be at the center, and we need also to be campaigning for, at the International Council of Nurses, at WHO, at all these organizations, which are national global organizations, to put pressure for better conditions and better pay and better training for all the nurses in the world. So enough preaching, I think. So join the movement and get your friends to join the movement. So, well, thank you so much, and wish you a happy Mother's Day. In England, I don't know if it is the whole of the world. Mother's Day is on Sunday. So we all have a mother or a sister who is a mother, or a wife who is a mother. So don't forget that, and have a lovely weekend. And see you at the next event that we do. We do webinars, we do lectures. This is the first what we call conference, and we had 176, I think, people who participated for most of the, who stayed with us for most of the time. And we had 300, and of course we had 370 who registered, but that is normal. Okay, take care, everybody. Bye-bye.
Bye,
Bye, everyone.
Bye, everyone.
Bye.